Good evening, everybody. My name is Jurek Pietrzak, and it gives me a great pleasure to welcome you all this evening. This is another WiSH webinar, which is the Wits Sports and Health webinar. It's done in collaboration with Josie, which is the Johannesburg Orthopedic and Sports Medicine Institute. And always it's supported by the South African Sports Medicine Association. Right at the off, I'd like to thank our sponsors, Acino Lita Pharmaceuticals, who have supported WiSH with an educational grant to make all these webinars free. It's really an honor to be able to welcome Professor Ponky Firer, who in South Africa is synonymous with knee surgery and orthopedic excellence. Professor Firer is a meticulous surgeon. He's a deep thinker. He's a caring doctor, and he's a superb clinician and really an absolutely excellent teacher. I knew him all through my time at King Edward's as one of our brilliant alumni. He studied engineering and completed a BSc and ultimately became an orthopedic surgeon when he saw the light. In 1982, he was awarded his M.Med. cum laude, having done a great deal of work on the anterior cruciate ligament. Incredibly, he's the founder and previous president of the South African Knee Society. He is a founder board member of ISACOS. He's an honorary life member of the Arthroscopy Association of North America. And he's also director of the Johannesburg Orthopedic Sports Medicine Institute. He knows knee surgery almost as well as he knows the fairways of the River Club golf course. I'm really looking forward to today's talk. In 2003, he produced a paper called The Anatomy and Biomechanics of the Medial Patellofemoral Ligament, which was published in the Knee Journal with his very good friend, Andrew Amos. And from there, he's built a lifetime looking at the pathology of the patella and patella problems. So I really look forward to today's paper and presentation. So over to you, Prof.
Well, thank you very much, Jurek. This webinar sort of talks are interesting because this is definitely the first time I've given a scientific talk wearing a pair of slippers. I also want to just confirm that when Jurek was telling you that I was a deep thinker, it was usually because I dozed off and they thought I was thinking deeply. So tonight I was asked to talk about the patella and particularly anterior knee pain, which some people consider as the backache of the knee. And I wanted to just on patella dislocations or instability, but I'm not sure that we're going to be able to do this in the time allowed. I hope you can all see the picture on the right, and there's a question and answer facility, as you know, and the first person who writes in as to what's unusual in that picture on the right of the dislocated patella will win a bottle of Rupert and Rothschild's wine. So start thinking about that. So at 7 weeks and 8 weeks already, even when some women don't know they're pregnant, their babies have already developed a patella. And as you can see on the right-hand picture, the patella is formed in concert with the trochlear and always matches the trochlear. And even at this early stage, you can see the medial and lateral patellofemoral ligaments over here and over there. The anatomy is mainly up of the bones. Patella has many shapes. It has a medial and lateral facet. The shape on the medial side can be very high, but its articular cartilage matches the articular cartilage of the trochlear. The ligamentous structures are really thickenings of the retinaculum, and we have both medial and lateral patellofemoral ligaments and patellotibial ligaments, or some people call them patellomeniscal ligaments, as there is an attachment to the meniscus in the front. Then if you flip the patella over, the musculature you are probably all well aware of. You've got vastus lateralis, rectus femoris, vastus medialis with its oblique portion. And we'll discuss a lot more about that just now. Of course, you need to know that there are nerves around the knee and they can cause problems on their own. They're supplied by the femoral nerve coming in at the top, and you've also got branches of the sciatic nerve, the saphenous nerve with the infrapatellar branch below the patella. Now, patellofemoral mechanics is very interesting. The key angle is 0 to 30 degrees, because in that portion of movement, the patella is really completely free. It's on the flat surface of the distal femur and the flattest part of the trochlear. It is protected with the patellofemoral ligaments and stabilized by these in this extended position. And the patella tracks from a lateral position in extension towards a more central position afterwards. If we look at normal alignment with the legs straight forward, and there's our patella. As we go into deeper flexion, the retinaculum and the medial and lateral patellofemoral ligaments, as seen on the side here, become lax, and the patella is able to glide from side to side. If the leg is now externally rotated, you get a slightly different tracking taking place. It starts off more laterally, but eventually centralizes. Internally rotate the leg, and you start now on the medial side. And as you'll see here, the medial patellofemoral ligament becomes lax, and it's the lateral patellofemoral ligament that is controlling this medial motion of the patella, which then tracks back into its groove. If you've got a laterally placed tibial tubercle with the leg pointing forward, you get a different form of tracking now. The tubercle, which attaches obviously the patella tendon to the patella, is now tending to pull the patella to the lateral side, and you get this tendency for abnormal tracking. You're getting increased tension on your medial patellofemoral ligament, whilst the lateral side remains lax. So it's really like a funnel effect, the patella. At the top of your trochlear, there's a big space for it to go in. It can move from side to side, but ultimately it gets into the deep part of the funnel and is stabilized by the bony anatomy. As far as contact points, when the knee is fully extended, the patella can contact off the trochlear on the anterior surface of the femur. And then gradually, as you go into 30 degrees of flexion, the contact area is mainly lateral. The patella starts lateral in its descent down into the trochlear, and you get a moustache-shaped contact area on the patella. At 60 degrees, you get a much bigger area of contact, as you see here and there. And at 90 degrees, it's still got good contact. But as soon as you get into the deep flexed areas of about 120 degrees, there are only small areas of contact medially and laterally, and on the femoral condyles medially and laterally. The trochlear angle or Q angle is of importance in terms of patellar tracking, and we recognize that taller people tend to have a smaller Q angle, where shorter people tend to have a larger Q angle, and particularly females with their wider pelvises increase this Q angle. And this is perhaps part of the reason why in anterior knee pain, women are more commonly the sufferers than men. Now, why is the VMO important? If you look at the force diagram on the patella, you will notice that we have the vector of the force of the rectus femoris, of vastus lateralis, and then there's a force of the patellar tendon, and all these three forces are pulling to the lateral side of the knee. The resultant of these three forces is a vector that pulls the knee laterally and into valgus. In order to balance this, you need a fairly strong vector, which is the vastus medialis, and in particular, vastus medialis obliquus, which pulls in that direction. The articular cartilage of the patella is the thickest in the body. It doesn't have sensation. There are no nerves in the actual articular cartilage. And if you've got chondromalacia patella, in other words, soft cartilage, the cartilage is not tender. And we'll talk more about that later. And there can be changes both in the quantitative, in other words, the amount of cartilage, and the quality of cartilage in pathology. So that's the end of the basic science of the patella and its femoral component. And that's the end of a ring-tailed lemur from Madagascar. And really, all you people should go to Madagascar. It's the most fantastic country to visit. Okay, here we go for this consideration of anterior knee pain. It's most common in adolescence, but it's very, very prominent throughout the whole population. Females are twice as more likely as males to suffer from this. And the sadness is that 70 to 90% of the people who suffer from anterior knee pain have recurrent or chronic pain. So when we now assess a patient, we've got to take a history. And we need to know where it is sore. And the first thing I always ask him is what I call the Cremora sign. It's not inside, it's on top. In other words, is the pain inside the knee, or are they feeling the pain on top of the knee? So we don't get misled by soft tissues on top of the knee or nerves that are causing their pain. And we need to know when it gets sore. Most patients will tell you that ascent or descent in stair climbing will give rise to their pain. Lunging or squatting will give rise to pain. You need to know if there's a feeling of instability. Now, this isn't a giving way of the knee in terms of the patella dislocating and patients falling to the ground. Patients may get a sensation of instability in their knee for a number of reasons, one of which is weakness of the quad muscles. And as they descend stairs, they require their quads to control the leg. And with weakness, the knee may want to give way forwards. And sometimes the patella does move and track abnormally and give the patient a sense of instability. And you also need to get a history of whether they've been overusing their knees. Are they knee abusers, long distance runners? Your examination, you start off with a standing view, so you get a very good idea of what the shape of the leg is, where their patellae are pointing. And then you look at them walking, and you look from the foot all the way up to the pelvis, because in each area, there are potential abnormalities that will give rise to the pain that they are perceiving in their knees. Sitting, the TTTG, or tibial tubical trochlear groove angle, what we do is you draw a line vertically down when they're sitting with their leg hanging over the end of the bed. And that line goes from the lower part of the patella vertically down. Then you draw a line from that point to the tubicle. And if there's an angle such as this, then there is a suggestion that the tibial tubicle is lateralized and you have an increased tibial tubical to trochlear groove distance. And then you need to watch the patella tracking. And this is a classic J sign of a patella that subluxes as you go into extension. When they're lying down, you can look for these two unusual signs that you get with patella alta. There's the dromedaris sign, where you have two humps. The alta patella causes a hump, and the fat pad is often enlarged in these patients. So at about 30 degrees, you see that double hump. And on the right-hand side of your slide is the grasshopper eyes, because these patella altas often have patellae, apart from being high, that squint outwards. You can assess their torsion, and you'll see the left-hand side has significant torsion of the femur compared to the right. And you need to assess the Q angle of the patient when they're lying down. The next thing is to decide how mobile the patella is. Does it move normally, mediolaterally? And roughly, there should be about 10 millimeters of movement side to side in a patella. We generally classify these in quadrants, where you draw a line down the middle of the patella, then you take the medial edge and the middle of that, and that middle line, and divide that in half again. And that gives you 2 quadrants medially and 2 quadrants laterally. And we decide whether the patella moves 1 or 2 quadrants or more mediolaterally. You also want to find out if there's crepitus in the knee. And what you do is you ask them to straighten their knee with a hip that's flexed and your hand on the knee, and they straighten up to the ceiling. And that's the best way to elicit crepitus. And you also want to assess tilt, as we see in this picture here, where you try and tilt the lateral facet upwards. And if it doesn't move, then you've got an excessive lateral tightness that can cause problems. You need to look at the retinacular structures and feel these. There are 2 areas that one gets tenderness with patella pain coming from the retropatellar surface area. That is the medial retropatellar surface, the star, and also the medial joint line can be tender with patella problems, and is often mistaken as a meniscal tear. And the days before MRI scans, and even today when people don't use MRI scans, a patient will present with pain, he'll be examined, or she'll be examined. They'll have marked tenderness on the medial joint line. The surgeon will say, oh, that's a medial meniscal problem. Jump in and do an arthroscopy, and they've had an unnecessary surgery. So you need to be aware of this. Then there's the step-down test. Let's see if we can get this started. This is Gareth Devine, the biokinetist, showing you how a step-down test should look. The knee should be able to stay outwards, and there's good control. If, however, there is poor control, as you see with this patient who's had a hop test done, they collapse inwards and go into what we call functional valgus. So you see, little things can cause big reactions. Okay, what about anterior knee pain? What are the structures that cause pain within the knee? There's the fat pad, there's synovium, and intraosseous pressure in the patella or the trochlear. Pain around the knee is the retinaculum, the patella ligament. We call it the patella tendon, but it's actually a ligament. The quadriceps tendon, and the nerves. You can get neuromas or entrapment of nerves. Under the knee, in other words, under the patella, osteochondritis dissecans, and stress fractures can give rise to pain in this area. And you can have similar lesions in the trochlear that give you a similar picture. But chondromalacia patella itself does not cause pain. It's the consequences of chondromalacia patella that cause pain. And these are flaking of articular cartilage causing synovitis, or not transmitting forces adequately through the sick cartilage, giving rise to increased pressure in the bone. Now you need to exclude other causes of pain that are not in, around, or under the knee, but may be felt in these areas. And obviously, I think you all know that the hip can refer to the knee, and one needs to examine this very carefully. The back can refer pain to the knee region. And a lot of people forget about this in patients who have had injuries and have become secondarily osteoporotic, and they don't have to be postmenopausal women. This osteoporosis allows for increased forces to go into the bone, and the bone is unable to handle them and gives rise to pain. Now, this final section, I think, is very, very important not to forget. And I'll just tell you about a couple of these things and a sad story. For those who don't know, an osteoid osteoma is a bony tumor. It's a benign tumor that pitches up every now and then and can be anywhere in the body, but particularly if it's in the lower limb, the hip, sometimes the lumbar spine, can refer pain down to the knee. It's a classic aching pain that is often worse at night and somehow is relieved by taking aspirin. So if we're not able to find a definitive cause of pain in or around the knee, and we're looking now for something else, a bone scan is worth doing to see if there is something like this that lights up. You must never miss things like sarcomas and synovial tumors that can present as classic anterior knee pain. We had in our clinic a few years ago a very sad story of a young girl, 16-year-old girl with anterior knee pain, treated very carefully by a physiotherapist, and the patient pain didn't get better. The physio quite rightly had x-rays done, which were reported as normal. And ultimately, she ended up at our clinic with our sports physician, who was at the time was working there, who just didn't like the whole picture and the fact that she had no improvement. So he sent her for an MRI scan, and that confirmed that there was an osteosarcoma in the patella, which is quite rare. The sadness was that the X-ray actually had changes suggestive of a sarcoma, which was missed by the radiologist. So the message we get here is always X-ray these patients. And if things aren't getting better, investigate further with MRI scans or with bone scans. So that'll give you something to ponder about while we move on to the next part of the talk, which is the patellofemoral pain syndrome. There are people around the world who break up anterior knee pain into patellofemoral pain syndrome and other causes of pain in and around the knee. So I'll discuss this section as PFPS. The commonest causes, what goes on with them. So there are a number of people who've done studies comparing patients with the patellofemoral pain syndrome with normal people and have found certain things that have taken place. Patellar maltracking is one thing that has been shown to participate in this patellofemoral pain syndrome. Draper used dynamic MRI squatting and showed that people with patellofemoral pain syndrome had increased lateral tilt and lateralization of the patella. Vitro showed that this crowd of people had hypermobile patellae, and Wilson showed that there was increased lateral translation, which is really maltracking, a lateral spin, and you look at little b in that picture there, how the patella rotates clockwise in a right-hand patella, and the tilt increase can be increased in patients with this patellofemoral pain syndrome compared to normal people. There's been a lot of study to show that the maltracking we get is due to muscle problems, delayed activation of vastus medialis, imbalances between medial and lateral structures, and atrophy of particularly Vmo. What we don't know is the chicken and egg story. Is the weakness that we see the causal factor of the maltracking and the pain, or is it secondary to maltracking and pain that the muscle now wastes or weakens and loses its normal function? We don't quite have the answer to that yet. Now, functional valgus is definitely a factor in patellofemoral pain syndrome, whether you have an increased quadriceps angle, a static one as the girl lying down, or the dynamic one that is shown with the Chris Powers test, and this increased dynamic valgus and collapse of the hip. torsion, giving rise to rotational malalignment. And what actually happens here, folks, is that the femur rotates, like this femur here is rotating inwards. The patella doesn't move. The patella is slung between the muscles above and the tendon below, and the femur relatively rotates inwards. So it is as if the patella moves laterally relative to the femur, getting impingement and getting increased pressure, causing the pain that we get with this patellofemoral pain syndrome. Then there are foot abnormalities. Barton looked at people with the condition compared to normals, and there was definitely a change in hindfoot eversion and increased tibial torsion in that group of patients. He also showed increased pronation and forefoot abduction. The ITB plays a role, and this dynamic valgus that one gets affects the tension in the IT band, particularly Kaplan's fibers, increasing tension in the IT band, which causes forces to change in and around the knee. And there's secondary maltracking and increased pressure on the patella due to this. And this is exactly what's happening, and the IT band then causes increased tension on the lateral side. There's also been shown that there's greater co-contraction of the quads and hams, particularly in females, and that they have a greater hamstring and gastroc force activity compared to men. And this increases the joint reaction force on the patellofemoral joint, giving rise to anterior knee pain. What I also would like to cover is this overuse and overload, and this envelope of normal physiology, which Scott Dye, a most wonderful orthopedic surgeon from San Francisco, gave us. And what he describes is that you can draw for any part of the body this envelope of normal physiology under which, if you are acting, you will remain in a good state. You will remain in what we call homeostasis, and there'll be no problems. Now, for example, if I stand on a chair and jump off, it'll be one cycle and the load won't be great. If, however, I now go to the top of a roof and jump off, again, it's only one cycle, but there's going to be excessive load on some part of my body and something will fail. I've gone outside my normal envelope of physiology for that part of the body. Now let's take runners or cyclists who will increase their load over a number of cycles and run a distance, but now they're still within their envelope and they're fine. But they don't recover by going back to normal. They don't end up down here if they have a day's rest and they start running the next day and the day after. Eventually what's going to happen is they'll start off not at zero, but somewhere around here. And then eventually they will exercise beyond the envelope of normal physiology and enter what we call a zone of supraphysiologic load. And once you're in that zone, you start hurting, you have damage. What happens to that particular part of the body is that its envelope of normal physiology shrinks. So whereas before you could run and activate yourself at this level over here without getting symptoms, now if you go beyond this green line, you will start getting pain. And this is the overuse and overload phenomenon. Okay, this is quite a busy slide, and there's going to be another one. It just helps to tie in how various things happen. And let's start at the bottom with our hip muscles. If we've got problems with our hip muscles, or we've got problems with our feet, you end up with a dynamic valgus. And that can go on to giving you a patella maltracking. You get a quadriceps disbalance, which affects patella maltracking, and patella maltracking can increase the quadriceps disbalance. The same thing, your iliotibial tract can end up being tightened, giving you maltracking, which affects your IT band again, and it's a vicious cycle. Added to this overload and the maltracking, you get increased patella and retinacular stress, giving rise to this patellofemoral pain syndrome. If you have problems with your hamstrings and imbalances, this goes towards your dynamic valgus problem, but also gives you flexion contractures, which occur also if you've got low back problems, giving you sacral inclination and a flexion contracture, leading up again to increased patella and retinacular stress and patellofemoral pain syndrome. Now, this is a very interesting question because patients have asked me this in the past and I didn't know where the pain came from. Pain only comes from nerves, and nerves get sore if there's an elevation of a particular neural marker, which we call substance P. And any richly innervated structure can cause pain. So where are the innervated structures in the knee? The retinacular, medial, and lateral has a tremendous amount of nerve supply. The synovial lining has nerve supply, and the fat pad has nerve supply, and subchondral bone has nerve supply. Now, let me tell you about this guy, Scott Dyer, that I was alluding to earlier. He, like me, also wanted to know what the areas of the knee, inside the knee, were painful. And so what he did was he got his partner to do an arthroscopy on his right knee, which he knew he had chondromalacia on. He had crepitus, he occasionally had pain, he had occasional effusions. And his partner put a little bit of local anesthetic into the skin, made the incision to push in the arthroscope, and then pushed the arthroscope into the knee. Scott Dyer nearly followed his name. He said that was the worst pain he had ever experienced. He wanted to die. And from that, he realized that the fat pad was an incredibly sensitive structure. So then the partner made another little hole and put in a probe, and he started probing areas of the knee. He probed the anterior cruciate ligament, and that wasn't sore. Only if he pulled very hard on it was there a funny sensation. He probed the articular cartilage, medial and lateral condyles, tibial plateau, not sore. He probed the synovium and pulled on that, and that was sore. However, when he probed the meniscus itself without tugging on the meniscus, there was no pain. Then he moved on to the chondromalasic patella, and he probed around and messed around in this articular cartilage, and that didn't hurt Scott at all. So Scott Dyer then realized from this that it was the fat pad, synovium, that are the most sensitive areas in the knee. And that subchondral bone pressure is important because changes in articular cartilage allow increased subchondral pressure. You have lost some of the shock absorption or force transmission in the knee, and then that subchondral bone sees this pressure and registers this through the nerves lying in that area of the bone. And both hyperpressure and hypopressure can cause cartilage degradation. So if you've got a patella that's not tracking well, it's lying on the lateral side in the trochlear, you'll get increased pressure on that lateral side, which can cause breakdown of the articular cartilage, which then will allow increased forces to be transmitted and give rise to subchondral bone pain. Or you may have on the medial side where you're not having the normal contact between the patella and trochlear, and that articular cartilage then softens because articular cartilage requires some degree of pressure to function normally physiologically. So the hyperpressure causes softening of the articular cartilage, which eventually can break down, and that can give rise to increased subchondral pressure. Now, where does the pain come from? What we do see is that there is a hyper-innervation in the lateral retinaculum. There's an increase in nerve fibers. There's been studies now that show an increase in nerves, particularly in the lateral retinaculum in patients with patellofemoral pain syndrome. And what they've noticed that there was an increase of this neural growth factor that led to this hyperinnervation. And what they found out was that ischemia gave rise to this release of this neural growth factor, which gave rise to the hyperinnervation. And where does the ischemia come from? From the functional valgus causing tension on the IT band and tissues on the lateral side, gave rise to a relative ischemia. It's not complete ischemia, but less blood flow than would normally occur. It's like having a mini tourniquet put on it intermittently, giving rise to this temporary ischemia. And what that does also causes a neovascularization, an increase in vessels in the area. And there have been studies to show that there's more blood vessels and more nerve supply in those areas. The neovascularization adds to the hyperinnervation in the lateral retinaculum, as I've discussed. And it's interesting because in patella tendinopathy, you see this increased nerve supply and increased new vessels in the fat pad. And they've also shown in patients with chronic back pain where the facet joints are involved, increased vascularization and increased nerve supply in and around that facet joint. So we can say that if you've got chronic patellofemoral imbalance, you can get some minor nerve injuries taking place. Now, if you're having nerve injuries take place, it affects your proprioception. So you get proprioceptive imbalances, and guess what this does? It aggravates your chronic patellofemoral imbalance. You can't control the patella movement. So the causes of patellofemoral imbalance are tight lateral retinaculum, skeletal malalignment like femoral torsion, knock knees, muscles that have gone wrong, if your tibial tubercle is in the wrong position, or if you've got a hypermobile patella and you've got multi-directional instability. So here we go again with another one of these organograms. And what I'd like to do with you is let's start at the top on this one. So if you've got lower limb structural abnormalities, you get patellofemoral imbalance. Or if your lower limb lacks dynamic control because of poor muscles, you get patellofemoral imbalance. This causes overload or stretching of the retinaculum, relative instability going on to anterior knee pain. On the other side of the line, you've got the patellofemoral imbalance, which can give rise to bony and cartilage overload. You get soft cartilage or broken down cartilage, early osteoarthritis. That will give rise to instability and itself give rise to anterior knee pain. If we go down to the bottom of this slide now, if you've got this ischemic thing taking place, as we discussed, related to this retinacular overload, going down, giving you ischemia, or you've got osseous hypertension taking place, you get loss of your vascular homeostasis. You get incremental increases in pressure. You get mechanical stimulation of the patella and the trochlear. Those intraosseous nerves get stimulated, gives you anterior knee pain. On this side, if you have a decreased envelope of function and you've now hurt yourself by pushing too far with overuse as well, you'll get a focal supraphysiologic loading of various anatomical normal knee components, bone and soft tissues, and they lose their homeostasis now. This will give you an increase in subchondral bone stress again, and once again, going up to anterior knee pain. I hope that's clear, but this is a very nice way of understanding the mechanisms of getting anterior knee pain. So let's not fight about what causes anterior knee pain and how it occurs. Let's treat it. So, which do you think is better, doing an arthroscopy and sorting out the inside of the knee and then rehab, or just rehab alone? There's no difference if you do arthroscopy and rehab or just rehab alone, and us surgeons are cursing this because that means we've got less work to do. But wait a minute, what about hanging articular cartilage? We see patients with anterior knee pain who don't get better. They've had all the conservative treatment. We now do an MRI scan and it shows hanging articular cartilage. We go in, we tidy this up, and they do get better. They may not get better forever, but they certainly get better for a good period of time. And what's happening here is that hanging articular cartilage can irritate the lining of the joint, setting up a synovitis, and we know the synovium is a painful part of the knee. So if we take away this hanging articular cartilage, which is a stimulus for a synovitis, they can improve. What about drugs? Anti-inflammatories, there's only weak evidence that they help. There's contradictory evidence with the cortisone or glycosaminoglycans, that's hyaluronic acid, and there's no evidence that platelets play a role in treating patellofemoral pain syndrome. Taping is very definitely shown to help patellofemoral pain syndrome. There was a very good meta-analysis done by Warden, and it's got to be medially directed tape put on by someone who knows what they're doing. Orthotics, the evidence is not definite here, but certainly there's been good results if there's significant foot variations like rear foot eversion and forefoot abnormalities, particularly when they combine together. Physical therapy, yeah, this is for the physios and the biokinetists. You guys are the most important people to treat this problem. And there's really the strongest of evidence that this makes a significant difference to these patients. The basic goals of rehabilitation, there's an early phase where you want to settle down pain and swelling and start getting your muscles going so you can get better tracking. You need to improve the tightness that has occurred in the quadriceps and lateral structures. And a lot of these patients walk badly. They have an abnormal gait pattern that you need to restore and thus decrease loading on the patellofemoral joint. We can then move on to the second phase where we now get onto more quad strength because without stabilizing the patellofemoral joint, if you overload the quads, you're going to hurt that patella. So we only get onto that in the second phase. You need to get better balance. That's improving your proprioception and specifically hitting hard on the core, glute, and hip strength, as well as your hamstrings and restoring good knee function. Finally, we want to try and return patients to their previous activity levels, and they have to be maintained. What about the psychological management of patellofemoral pain syndrome? Well, I think chronic pain that we see has really three factors. There's the biologic, the biomechanic, anatomic factors that we've discussed. Social environment plays a role, and this is where a lot of the overuse, overload stuff comes in. You know, you're a runner and you run with your mates, and now you've got a bit of a sore knee, and now come on, it's Sunday morning, come for a run. That needs to be managed very carefully. There needs to be a concerted effort at changing their lifestyle to suit their knees, because we can't change their knees to suit their lifestyle. But very definitely, there is an anxiety and psychological distress in a lot of these patients that plays a major role in chronic pain management. And I really would love to see someone set up an anterior knee pain clinic in Johannesburg where you have physiotherapists, biokinetists, sports psychologists, and psychiatrists, all lending a hand in managing these patients. And I think we probably would get better results if we had a combined effect. Okay, Jurek, I've done my talk. if there are any people, you will be able to tell us who's the first person to tell us what is wrong with this, or not what's wrong with this, but what's unusual about this. So while we see if people put in questions and answers, I will say thank you. That's the end of my talk. One day go down to Knysna and have a lekker braai at sunset. Thank you.
Thank you very much, Prof. That was absolutely superb. I think you covered everything in crystal clear detail, and there's certainly significant food for thought. There were some correct answers to that question. Unfortunately, I've managed to lose who answered that correctly first, but perhaps Robin can give us a hand there. I noticed that you didn't go into any surgical treatment and surgical management. One of the things that I find in my clinic very often, Prof, and it's is when a patient comes in and they tell you about this anterior knee pain, they lament how their life has been affected, how incredibly difficult it is to go and exercise and things like that. And when you examine the patient in their entirety, and then you tell them that they need to go and do physiotherapy because they've got a weak core and a weak VMO, they look incredibly disappointed, almost as if you've shortchanged them through all of this. So my question to you is, when do we actually delve deeper into the evaluation examination? Is an X-ray a must? Do we include a hip X-ray at the outset? And when do we start including things like CT scans, scanograms, to start assessing for rotational deformities, et cetera, et cetera?
Can you hear me?
I certainly can, Prof.
Okay. So I think the first line management is a full assessment of the patient, and you can note down that there are certain anatomical variants that may ultimately come to surgical correction. Things like torsion, things like tibial tubercle lateralization. But the other side of the coin is there are so many of these patients that do improve with those so-called variants or abnormalities that one doesn't want to get into surgery too soon on these patients, because a lot of them can be very disappointed. The two procedures that actually help the most are patients with significant torsion, and you derotate them and they get better very rapidly. The other one is patients who've got what we call a lateral hyperpressure syndrome. These are patients that are born with a relatively, or develop a relatively tight lateral side. Their retinaculum is tight, the IT band is tight. You can't stretch them. And if you X-ray them and look carefully, you will see that the trabeculae and the patellae have changed direction. They are aligned laterally towards the lateral trochlear, indicating that that's where there's a lot of stress going through. Now, those patients do very well with a lateral retinacular release. And one is always on the lookout for them, because if they don't settle within 4, 6 weeks, 8 weeks of proper stretching, and you know that their core and that is quite good, then they're worth doing a surgical procedure for. But surgery, the problem with doing surgery on these patients is it doesn't always cure them, because if they haven't done all the other stuff and got everything else in place, they're going to be very disappointed.
Absolutely. I remember doing my fellowship with you and always telling me about the VMO being the real difficult chap out of the 4, because they certainly are the first to waste in any pathology, and then they really are the most difficult to rehabilitate once you've tried to treat them. So there's a question in which they ask, is there any particular exercises which one can isolate the VMO, or are you actually strengthening other muscles that are already strengthened? And then the question becomes, should we be sending our patients to physiotherapists that are notorious knee physiotherapists, and how often do they give you feedback? And then on that, should there be greater dedication towards having anterior knee pain scores? We know that the Kujala score is one of the scores, but it's really not really very user-friendly, and it's very difficult. And is that something that on a forum like this, we should start working towards, where we can start following up our patients' functioning? So there's 3 questions in one there, Prof.
Okay, let's start with the first one. You wanted to know about the VMO.
Yes.
So I believe that the physios and biokinetists can do exercises and stimulate with electrodes as well, the VMO, to re-educate the patient's feedback in how to contract that VMO. A lot of patients, inverted commas, forget how to contract their VMOs. So one has to reintegrate that whole circuit again and re-educate the VMO to contract. The patient that you've got a real problem with is, if you're going to look in surgery, and we see this, and you'll be aware of this, Jurek, whether you're doing knee replacements or other surgical procedures that are open, there are a number of patients that have medial vastus, including the VMO, that are very distant from the actual patella. They don't come all the way down to the patella, so they don't have the same beneficial effect, and those are difficult. And some of those, if you ever get down to doing surgery on some of these patients, you may have to advance that VMO to allow it to have a better dynamic effect. What was the second part then, Jurek?
So the second part was any exercises that you recommend for these patients, and are there physiotherapists that should be dedicated towards treating these anterior knee pain? And I love the idea of a multifactorial, multidisciplinary clinic. I think that's certainly something that we should be looking at more and more to treat these very difficult conditions, such as anterior knee pain.
Yeah, I agree. Throughout the whole of orthopedics, we need these more specialized clinics where you have a whole group together. But I think the person to be treating them is a physio and or a biokinetist who has a specific interest in this. And I think all well-trained physiotherapists and certainly all biokinetists should know and understand the underlying causes and problems of anterior knee pain, and know how to go about rehabilitating them. One of the things that a biokinetist taught me, which I now use for my patients, is when you go up a step and you push off on your toes, you use your quadriceps, and that puts increased force on your patellofemoral joint. If you go up and you press on your heel so that you can actually lift your toe off the step, but the weight's going through the heel, your glutes and your hamstrings are contracting more, unloading the quadriceps, unloading the patella. So that can already give patients a little bit of relief. So there are little things like that that you can help them with. So yes, I think really, like all orthopedic surgeons should be able to manage most conditions, all physios and all biokinetics should. But you do get physios who are specifically interested in this, and those are the ones that we tend to refer to. The other aspect of this, which I think we forget, and that comes into the psychological chronic pain thing, is pain clinics like the one run by Phyllis Berger, for example. Those have a major role in helping these patients, because people who are trained like she is, using Eastern and Western medicine, have many other modalities that will help them through their pain while they're getting on with the rehabilitation program. And that is a very key issue. Some patients really need that.
I've been hogging things, but I think this is really fascinating. The role of an anterior knee pain score that we should maybe be using in and amongst surgeons in South Africa or in Johannesburg, so that we can follow these patients up. And I think something like that, even in our total knee replacement patients, really is something that's certainly lacking in the literature.
Yeah, Jurek, I'm a simple guy, so I use very simple things. The Kajula score is good, but it's not easy to administer and follow and etc.
Exactly.
You're going to write scientific papers that you need presented, and you've got to use that. I use a simple visual analog scale for two things. One is pain, and 1 to 10. And if the patient's numbers are coming down, then you know they're getting better. And the other thing is patient satisfaction. And they can mark that also on the visual analog scale, and that gives you an idea of how they're progressing with regard to that. It would be nice to be able to put a number and sort of isolate various aspects of the knee and function and see whether we can collate that there's improvement or not improvement with one or other modality.
So I've got some questions from the attendees, Prof. Should all trochlear dysplasia patients, those with less than 11 degrees, be referred to an orthopedic surgeon for investigation? Or should a conservative management program be attempted by the physiotherapy therapists? And if so, for how long?
Okay. Trochlear dysplasia is a major cause of recurrent patella dislocation or subluxation, but it is also a cause of anterior knee pain because the patella wobbles around and takes abnormal loads. I think it should be noted, but it would be very rare to be doing things like trochleoplasties for anterior knee pain in these patients, as it is very rare to do trochleoplasties on patients with recurrent instability. But these patients definitely need to do an extended rehabilitation protocol first. And if you feel that the patella is subluxing back and forth, giving rise to problems, one may want to attend to the soft tissues before doing bony work, because the outcomes of trochleoplasty are not all that great, despite the guys who proponents of it tell you.
Just quickly on that, as a robotic knee surgeon myself, and dabbling in and hoping that robotic surgery can really change the landscape of orthopedic surgery, do you think very quickly that there may be a role for robotic knee surgery in the future, making these very technically challenging surgical procedures where there was a little bit of a thumbsuck? Do you think we could maybe start manipulating the anatomy a little bit more accurate with the use of robots?
Okay, Jurek, I have the following view on robots. They are fantastic innovation. They give you a lot of information. At this point in time, we can't really say that they get better results than carefully carried out other procedures. However, the feedback we get from robots and the ability for robots to differentiate small increments in things like soft tissue tension may be a very important role when you start doing surgery on the quadriceps mechanism, because it would be really nice to be able to titrate, like an MPFL, to titrate the exact tension that you put on the MPFL. You may get to a stage where you'll be able to temporarily fix your MPFL, translate your patella. The robot would feed back and tell you that's giving you 3 millimeters lateral movement. And your normal knee, which you've tested with the robot before, also gives 3 millimeters. Then you know you've hit the target. Yeah. So yes, I think there is very definitely a role for robots in the future in all areas of surgery.
Prof, imbalance is a big problem, and throughout my training with you, you were very strict on isometry and balance. Everything needed to have a balance between it, whether it was varus valgus or whether it was flexion extension. So on the theme of balance, do you think that an imbalance between hamstrings and quad strength may play a big role in anterior knee pain?
Yeah, very definitely. I think you're getting abnormal forces if you've got that sort of imbalance. And this is one of the factors that they've shown in women, that they have excessive hamstring strength relative to quads, and that then gives you these abnormal gait patterns that they get, and the decreased quad therefore gives you less control of your patellofemoral joint. So yes, that's definitely a factor, and we're getting pretty good. The biokinetics, particularly now, are doing decent assessments of these various functions of quads and hams together, and their ratios at different speeds as well.
Prof, I'd like to congratulate Floyd Labate, or Labate, please excuse my pronunciation, was the first person to answer your question. And on that note, looking at that medial patella dislocation, can you just give us a
whoa. You guys got it all wrong. Medial patella, let's go find, can we try and find that picture? Let me go find that picture for you. There's a trochlear. There's your patella. Which is medial, which is lateral?
Well, you'll have to tell us, Prof, because we've obviously all got it wrong.
This is actually a lateral dislocation of the patella, and the unusual thing with this is the very prominent lateral trochlear, which is normally more prominent than the medial.
Oh.
Very unusual.
Evan Speechley did get it correct. He said it was a lateral displacement.
Yeah, but the unusual thing about it is that the trochlear is still big. Okay. So.
Well done to Evan, another King Edward's boy.
Okay.
Okay, brilliant. Thanks. So, talking about medial instability, have you ever seen anything that's unrelated to an iatrogenic cause, or is it always iatrogenic over tightening or something that a surgeon has done wrong?
Okay, the commonest cause of medial dislocated patella is an excessive lateral retinacular release. There is described in the literature cases of medial dislocation of the patellae without prior surgical involvement. And these are often these very small patellae that some patients are born with. Together with a small patella, they actually have a small trochlear. They're very hypermobile, so the patella can go in either direction. But that, as far as I know, is a very rare condition. I haven't ever seen that. I've certainly seen it in patients that have lateral releases. And the way to diagnose that, if it's the right leg that you're worried about and you're not sure if they're giving way because the patella is going laterally or medially, you lie the patient on their left side, you hold the right leg up, you have them relax, and you'll see the patella move medially by gravity. And then you know that that patella is unstable medially.
Great. Prof, I've got a silly question. I loved your diagram looking at load versus number of cycles. We very often have these patients coming in and they tell us that they're trail running and they're doing 189 kilometers every day and they've got this anterior knee pain. Is there any benefit, and as we've mentioned that there's the social environment and they feel their pain because they're missing out on, is there any benefit by telling our patients to change from running 180 kilometers to trying doing something like cycling or even changing to swimmers, or is that no benefit? No. Are they going to do what they're going to do, and there's no benefit in changing their activities?
Okay, when you get to my age, you get to understand that you can take a horse to water, but you can't make it drink. You can take a runner to a bicycle, but you can't make him get on it. There are a lot of runners that refuse to take up cycling. But I tell them, we can't change your knee to suit your lifestyle, so change your lifestyle to suit your knee. There are a number of people who have converted, say, from running to cycling or from running to walking or doing something different that will give them the adrenaline or hormonal rush that they get with the exercise. And understand that. I've been in sports medicine for 40 years. I'm a sports person. I would hate not to be able to play my golf now or to cycle as I used to if I've got injured. So you really have to have sympathy, empathy with these people, do everything you can to get them back to something that they can do that is not going to affect them or hurt them. And that's really where it is. And just if I may interrupt, I've just opened the chat here, and I see that someone said it was a medial dislocation. Then Lauren Brown, to panelists, it's lateral. Fibular head is on the same side. Clever girl. Well done, Lauren. And then Floyd Labati says, is that an abnormal trochlear? Well, it is an abnormal trochlear because it's got a very big lateral side. So I'm happy if Lauren Brown and Floyd Labati can contact me. They can each get a bottle of wine. We'll arrange that. If you can let me know where and how you are, and I'll get you a decent bottle of wine for your efforts. Okay.
Brilliant. There's just one question from one of our registrars, Prof. He's asked about the step-down test, about its evaluation and validation, and then also about Scott Dye's experiment. He wants to know if the ACL was agitated and was only minimally tender, where does the pain come from in anterior cruciate ligament tears?
Okay, so the first part was the
step-down test.
Step-down test, okay.
And so, Chris Powers test.
Yeah, that's a Chris Powers test, as I learned it from Chris Powers when he was out here. And what you're doing is you are asking, and we do this in our rooms when I look at patients now. I've got a little step. I ask them to step down halfway down, and you will see those patients who've got good glute control will stop their hips from internally rotating. The hip internally rotates and the knee collapses then into valgus, a functional valgus. And they sometimes can't even hold themselves in that position. You saw from that video of Gareth Devine on how a normal patient with normal core strength steps down, the kneecap points forward, in fact it points a little outward laterally, and they don't drop the hip down at all, the hip stays stable. It's like almost like a Trendelenburg test. If you've got good glute muscles, your pelvis doesn't drop when you're doing a Trendelenburg test. The next thing was the Scott Dye. What Scott Dye found was that your anterior cruciate ligament has a film of synovium and vessels over it, because it actually is a retro-articular structure. It's not in the joint, it's behind the synovium. And it's got a strong plexus of nerves. Just tugging on it, which is what happens when you run and you change direction, you get a tug on your ACL, sends back a feedback mechanism for you to contract your muscles to stop you from going into an internal rotation valgus position that would tear up your ACL. Those are part of the feedback mechanisms that protect you. What happens when you tear your ACL? Then, firstly, you tear asunder some of these nerves, and that hurts. But the pain also comes from the hemarthrosis that you get and the synovitis that you get. So I think those are the more common areas where the pain comes from. When Scott Dye had his ACL palpated, he was aware of it and was a bit uncomfortable, but it wasn't excessively painful. We don't know what force the guy did in terms of pushing on his ACL. So that there's no formal evaluation of the amount of pressure.
So, Prof, I think you've really done an exceptional job today. I really just wish I was a better surgeon, because I realize now why you pushed me so hard to start looking at the hip. I obviously was never good enough to stay at the knee for very long. But in conclusion, if I may simply, what you've told us is that in order to treat anterior knee pains, we certainly need a keen anatomical knowledge, and we need to evaluate the anatomy from top to toe in its entirety, and literally from hip to toe. The causes are multifactorial, and therefore the treatment should be personalized to all the patients. And this is the only way really to avoid failures and to try and avoid subsequent unnecessary operations. Non-steroidals and PRP and corticosteroids really don't have a great place and are relatively unsuccessful. Taping is excellent, but should be done by the experienced and the skilled. And really our physiotherapist and biokinetic partners really hold the key to making us look good, and the strongest evidence for success lies with them. And then, of course, I think you've really planted a tremendously exciting seed by talking about a combined clinic in where we try and work together as orthopedic surgeons, biokinetics, physiotherapists, and psychologists, all to try and get our patients back on the proverbial road.
Thank you very much, Jurek. And just for everybody out there, thank you for attending. Just to let you know that Jurek actually is a very, very good hip and knee surgeon, and he was a wonderful fellow to work with. And I'm quite honored that you chaired this session, Jurek. It was lovely to see you telling me what to do for a change.
No, the honor was all mine. Thank you very much, Prof. It was really super.
Thanks, everybody.
Indeed. Thank you very much, everyone, for attending tonight. Tomorrow's session is at the same time, same place, and it's about cycling. It's a cycling interest group hosting a webinar about the victory of last year 2020 Tour de France. So please come and join us. We've got two preeminent cycling physicians, team physicians joining us tomorrow night, and we look forward to that. Thank you very much all for attending tonight. Thank you to our speakers, and thank you very much for an entertaining evening. Good night, everyone.